Well, welcome everyone to our third Sunday forum. As you see on the slide, the title of our forum today is COVID-19 and Mental Health Lessons from the Pandemic. And our presenter this morning is Dr. Mark Williams. He received his doctorate degree at the University of Minnesota and his residency training in psychiatry at Mayo Clinic. He is an associate professor of psychiatry at Mayo and has authored over 50 articles and book chapters, mostly on the topics related to integrated behavioral health. He has been a leader in the translation of evidence-based models of care coordination into primary care practices for adult and child depression in patients with complex diseases, both at Mayo and as a part of state and national initiatives. He currently leads the research group within the Division of Integrated Behavioral Health at Mayo in Rochester, Minnesota. Mark, you might want to just tell us a little bit about what the integrated behavioral health means.
Well, thank you for can you hear me well?
Yes.
Yeah, thank you for the introduction. And actually the integrated behavioral health part will come up in this talk.
Okay.
But just to give you a sense, it's kind of fun for me to give a talk to Christ United Methodist because that's go to my home church. So it sent us to Pakistan and back. So nice to be, in a sense, back home in a way. I'm a psychiatrist at Mayo in Rochester. I work in the Baldwin building mostly, if you're familiar with that, and out at the Southeast Clinic. So most of my time as a specialist is being embedded in the primary care setting, where we try to see people early in the course. And my sort of passion is trying to figure out how to see patients with mental health problems early in their presentation, so that we can maybe prevent a lot of the suffering and outcomes that come when things are left without being addressed. So that you'll see that coming through in some of this talk. And I didn't put in a ton of slides because I wanted some time for conversation and questions. But let me see if I can advance this. So these are just three different slides, pictures off of the internet about the Spanish flu, which happened 100 years ago now, kind of interestingly. So you can see there's a sign in the stockyard about the Spanish influenza endangering the war. And they're saying there have been 30 deaths in the Navy Yard, and don't spit was one, not to spread the influenza. And then there's a notice in the top right. And then interestingly, in the bottom right, I just thought it was interesting to know that this happened around the time Babe Ruth started. And there you see a baseball player who is wearing a mask. So when we have all this anti-mask kind of sentiment, but the same thing was happening 100 years ago where people realized at some point they had to wear a mask. And the Spanish flu was from a related virus, H1N1 virus. And I don't know if folks probably know a lot. I'm not an expert on the Spanish flu, but it's interesting that it was called the Spanish flu mostly because of the press. In Spain, they had free press. In other places, there was censorship. So the free press is presenting all the deaths related to the flu. And so people called it the Spanish flu. So that's one of the challenges of trying to tell the truth, I guess. It impacted about a third of the world's population at the time, about 500 million, and about 50 million deaths, although that's really kind of an estimate because it wasn't reportable. The flu wasn't reportable when it started. And the mortality was higher at that time with the younger folks. It really did seem to hit the young a lot. And in the US, there were over 600,000 deaths, often within 3 days of the infection. And they had, imagine that they had no real vaccines. They tried to develop vaccines around bacteria, but they didn't have the right technology at the time. So everything was managed through isolation, quarantine, personal hygiene, and disinfectant. There's a little, if any, mental health research about the mental health aspects of the Spanish flu. There's this one paper that was interesting from a guy in the Scandinavian countries looking at asylum hospitalizations in Norway. And there was an increase in psychiatric hospitalizations about 7 times in the 6 years after the flu. Survivors at the time were complaining of sleep problems, depression, mental distraction, and other, you can see the other symptoms they report. And the death rates were higher, with suicide being a part of that. The social impact that we'll talk a little bit about with the current pandemic was also obviously a problem then. There were 31,000 children in New York who had lost one or both parents back in November of 1918. So when we switch to the present, this is another virus, the SARS virus. It's similar to the other virus attacks that we've had with MERS and other SARS viruses, other COVIDs. And it has a direct impact, of course, on the body. And you can find the virus in the fluid that surrounds our brain if you do a lumbar tap, for example. So it does get inside. One of the things you always wonder is, can something get across this barrier between the body and the brain? And the ways that this virus could impact your neurological or mental health can be from inflammation, which is what is a lot of what we see in the medical conditions. It can be from your body's defense system, the cytokines that overreact in a way to this infection. It can be, secondary. We've heard about clotting problems in people with this virus, and strokes. And many of the drugs that are used could be secondarily causing mental health problems, steroids, for example. So there's several ways that you could think about a direct effect from this virus biologically. And a study during this pandemic of about 40,000 patients showed about 1/5 of them had neuropsychiatric symptoms. So they're not rare. And in previous epidemics of this type of virus, we saw, looking back, issues like confusion, depression, and a third, memory problems, insomnia, and then the steroid-induced psychosis. That's the drug effect I mentioned earlier. And there was some longer-term issues of depression, insomnia, anxiety, irritability, fatigue, and in some post-traumatic stress disorders. And we can talk about any of those if you have questions about what some of these things are. There is a lot that could be said, of course, and you've seen it in the news, on the psychological and social impacts, which one might argue are bigger than the direct effect and affect more people than the one who has the virus in a family, for example. There's isolation, unemployment, financial issues, fear, loss. Many people have had losses during this pandemic. There's increased use of addictive substances. Sales of alcohol have gone way up during our pandemic. And then the impact on life's journey. People are starting school and trying to understand how to be social with little kids in school, or your high school prom you might have been looked, or your graduation, births, marriages, funerals, all of those natural events that we all look forward to or have traditions around have been impacted. And trying to get to work or school via Zoom particularly challenging because it's hard. I have lots of patients coming in now saying that they think they have attention deficit disorder. And they may have had it before, but now they're trying to work from home while their spouse may be also working from home with dogs and cats and kids running around at the same time. And it's very, very difficult to be as productive when you can't have the office you can put yourself away in. And there's a little humor about that issue. This little child comes in, wakes their parents up and says, I had a scary dream that I wasn't getting any attention. And that's sort of how a lot of our patients are feeling, that although they have had some bonding time, but they're also trying to get sleep and get focus, and they'll come in to see mental health providers because of all the distractions. Now, this is one of those sort of chicken or the egg questions. Does COVID-19 lead to mental health problems? Or do people who have mental health problems more easily get COVID-19? It turns out that both are true. This is an interesting study that just came out last year, where they looked at about 69 million US patients. And they could look, because they had longitudinal information, they could look at those with no mental health diagnosis in the record. And they could see what was their risk of getting a mental health diagnosis if they got COVID. So compare those that didn't get COVID and those that did, and what was the percentage of having a later mental health diagnosis during a time window. I got up to about 3 months. And you could see that the risk of the first psychiatric diagnosis, that the person had never had one, was about two times what if you didn't have that. And you can compare that to respiratory infections, which one would think with the scarring and damage to the lungs would be higher than a mental health problem, but is actually lower. The incidence of any psychiatric diagnosis after the infection was about 18%. Now, looking the other way, let's look at people who have mental health diagnoses already in their record, and now look forward to see if they are more likely to get COVID than those without mental health diagnoses. And that was also true, about a 65% increased risk of getting COVID if you have a mental health diagnosis. So it's an interesting thing that to think about as to how a mental health diagnosis might be linked with all kinds of risks for being more susceptible to illnesses. And I will talk a little bit about how people with mental health diagnoses often die earlier than those that don't. And also how having COVID can be a very stressful thing and lead to mental health problems. Just picking on one of the mental health problems, I wanted to show you another study. This is a national survey before and after COVID-19 started. Around 5,000 people before and about 1,400 people after. They used a simple tool that we use in primary care psychiatry called the PHQ-9, Patient Health Questionnaire, 9-item, to measure symptoms of depression. And you can see that the prevalence or the presence of depression was higher in every category of depression as compared to before, with about an overall 3-fold higher symptoms of depression during the pandemic. Now, among those that had the depressive symptoms, those that are lower income had a higher, about 2.3 times higher risk. Having less money in your savings was showing a sense of higher risk. And those, of course, who were undergoing a lot of stress had about a 3 times higher. So we are seeing a lot of patients that are needing our attention in mental health right now during this pandemic, and it's been hard to keep up with the demand. I wanted to single out one of the subgroups. There are multiple subgroups that we don't have time to talk about who are more at risk for mental health problems. But because of the presence of Mayo here, I thought I might single out a little bit the healthcare workers themselves. We're seeing more of our own colleagues needing help. And this is the desk people, folks from the desk. This is people who are rooming patients. This is people in the ICUs. Constant exposure to death, especially when you're not able to impact the outcome. Long shifts, our exercise locations closed down, which might have been a way to recover. Limited access to PPE or protective equipment and ventilators early. I don't know if you remember that period of time in the pandemic. And you feel as a healthcare provider that you're risking your own life in your job, but you're also risking your family when you come home. We see an increase in burnout in certain groups, and there's the highest depression symptoms, anxiety and stress seem to be in nurses, female workers, those in the front line, younger medical staff, and of course, those with the higher infection rates. Incidentally, the first publication in this last couple years on COVID related to mental health was in healthcare workers. It's in China, where the workers exposed to COVID-19, about half of them reported depressive symptoms, 44% reporting anxiety, about a third with insomnia, and overall distress in the majority of patients. Those with closer contact with COVID patients, of course, had a higher risk. The other thing that I help organize what's called a morbidity and mortality conference at Mayo in psychiatry, where we look at things that didn't go so well and patients that had negative outcomes, not necessarily because we did something wrong, but how could we make that better experience. And we were talking about a healthcare worker that had a negative outcome, and it led to a conversation of the culture of healthcare. It's hard sometimes for healthcare workers to seek help and go to the mental health team. If you take time away, I remember as a resident, if I took time away for a cold, that meant someone else on my team would have to do double work. And so you don't want to have that fall on someone. There's also a stigma everywhere about mental health, including those that are trained in medical health. There's a concern about confidentiality. We often have healthcare workers are fearful to go into our psychiatric facility or see someone inside, and there's a tendency to want to demonstrate strength. For those that are taking care of that patient, there may be a hesitancy to see how sick somebody is as a healthcare worker because of a sense that they'll tell me if they're really not doing well. And there may be a tendency to want to expect that they are telling you everything that's going on when they may be trying to present a healthier exterior. And being hospitalized on your own medical unit, I had a patient, one of the COVID staff, who developed COVID and ended up being in her own ICU on a ventilator and nearly died, came out and recovered, but the indignities that we all know about that come along with being on a ventilator and being cared for by your colleagues and then going back to work on that same unit is she's had some post-traumatic stress symptoms. And then the knowledge and the guilt that's associated if you retire early or leave the healthcare system in the middle of a pandemic may push people back to a work setting too early. So it's important to think about, and we could look under the hood on other subgroups. This isn't to say that other subgroups don't have difficulties. I just thought I'd focus a little on this one. And mental health is not always well understood or valued. This is a cartoon from the New Yorker showing these people going up to therapists almost like they're bandits, saying, let's get in, let's get help, and let's get out. And that's kind of the way some people look at mental health and getting care, that it's something to be sort of avoided. Well, just like we know that the virus impacts individuals with health that are susceptible you know, the people who have underlying health conditions are more at risk. We've heard of that. It also reveals weaknesses about our systems of care. And, and it shows, it's like a test to show how our public health system medically has been weakened and not supported like it should be. And here's some of those examples. Tracking patients, we were struggling with, do we know how many patients are positive across the world and across our own country? Then there wasn't the infrastructure for the genetic ID. We've had shortages in safety equipment and in testing materials. There's obviously huge disparities in access to healthcare that predated COVID, and we're seeing that now in vaccinations as well. We've seen the challenges of the politics that can enter the public health system and not knowing who to trust about information, which is actually, as I understand it, true 100 years ago as well. We also see the need for public and private partnerships that were less common before around vaccine development. There were a lot of regulations that slowed vaccine development that maybe some are necessary, but some may not be. And we've seen some speeding up of that. And then, of course, the impact of social determinants on being able to fight off a virus or survive with a virus, broadband access, isolation, and poverty. There are reasons for hope, though. Looking back, the cholera and typhoid outbreaks led to improved water management and sanitation. Malaria and yellow fever led to increased screens on doors and windows and mosquito control efforts. So what will happen after the pandemic? Well, we're already seeing the impact on vaccine development, but will we see an improvement in our public health system? Do we have the will to go past this and make it better for what comes ahead? And what about mental health system changes? Will we take what we learn here and apply them? Well, to understand that, you need to look at the mental health system before the pandemic. And mental health conditions are really common, actually, and very costly. About 1 in 4 people, it turns out, will have a mental health condition in their lifetime. So that's a lot of people. And I would guess that if we had everybody talking frankly, that most people in this conversation, like in most conversations, would personally know someone who's had a mental health problem. Those with mental health diagnosis die 10 to 25 years earlier. Now, what's that about? Well, it turns out that people with schizophrenia or bipolar illness, some of our more serious mental health problems, they die of the conditions that you see in metabolic kinds of problems that with strokes and with diabetes and heart failure much earlier than people who have those same conditions but don't have mental health problems, which has led to a lot of concern that the primary care of those with these illnesses is not meeting them or not finding them or not being connected to them. 70% of youth in juvenile justice systems have a diagnosable mental health condition. And one could look at that and say, now, what are the odds that that's random? Or is there a sign that it's hard to get access to mental health resources and things end up heading in that direction? And you see that in adults as well. And suicide has been rising in the youth. It's a leading cause of death in those ages 10 to 34. So there's a lot of need out there, and almost 60% of patients by some studies really, although they have mental health needs documented, receive no treatment. Would we stand for that if it was tuberculosis or if it was cardiovascular disease? Is kind of the question some of me and my colleagues ask. Access to psychiatric care is very poor, often waiting 2 or 3 months. There's a study where some folks pretended to be patients, and they called around to different mental health providers around the country, and they tried different insurances, and they had a lot of trouble even getting a hold of somebody. And the first appointment ranged from 1 week to like 3 months. to get an appointment. And over half of the psychiatrists in our country don't take health insurance. They only take private care. So there's a lot of challenges right out there for people to get seen by mental health providers. Patients can wait in our emergency room at Mayo for over a month waiting for a hospital bed in just basically in an emergency room rather than actually in an inpatient bed. So some folks have said to fully staff the current system using the way the system is currently designed, which I'd argue is the part of the problem, you'd need about 4 times the current resources. And that's not likely to happen, of course, as we know. So what would be some changes that could happen to our health system, mental health system? Well, we need to get creative about how to get an assessment. Right now, it's too complicated and costly. One of my mentors shows a slide with silos, and people from the Midwest obviously know what silos are. And he says, well, what if you have a problem with addiction and with a mental health issue and a financial problem? You have to go to 3 separate silos of care to get help. And it's very confusing to know how to navigate those. And the people who are navigating them have mental health issues, which makes it harder for them to process. So if we keep our system to where we need a specialist to evaluate only, we're understaffed by far. So some of what we do in integrated behavioral health, which I'll be talking about, is to try to help the people who see that patient the first time know how to begin the process of evaluating and caring for the patient. Telemedicine prior to the pandemic had lots of rules that were making it very hard to do telehealth. You couldn't do this across state lines. You had different rules for different insurance companies. It made it very challenging. And the stigma, of course, has not changed in mental health. One of my colleagues is studying this issue and trying to figure out how to help with the stigma about mental health problems. We've made some progress on that. We have a long way to go, because even though we have parity legislation, frequently I have patients who are not getting things covered, but if they were medical problems, they would have them covered. There's also a delay in care, and this delay leads to higher morbidity, mortality, and cost. I'm giving 3 examples purposely here because we have little projects on each of these. Eating disorder, for example, if it's not addressed and managed early, can lead to a mortality rate of 20%. That's the highest mortality of any of the mental health problems. And the challenges is there's very, very little insurance coverage for adult eating disorders treatment, and so many people can't get help with that. Substance use disorders, there are people dying, this is an interesting statistic, 29 people die in a motor vehicle accident involving alcohol every day in the US. So we have a lot of room for improvement on early identification of substance use disorders. We know about the opiate epidemic. The alcohol issue is even worse in some ways than that, and it's sort of become normalized in some ways. And depression is among the top 5 worldwide conditions as primary causes of disability. If you look across the world, cardiovascular disease and some infectious disease, depression is right up there in terms of how many people are struggling to work and to function without adequate treatment. So what are we doing with integrated behavioral health? It relates partly to this. Integrated behavioral health isn't going to fix all these problems, but it has some reasons to be hopeful. I was working in specialty care in various settings in the Twin Cities before coming to Rochester. I've worked in a kind of an HMO clinic, an inpatient psychiatric unit, a homeless program, a refugee program. And I was realizing that we need to move upstream to where patients present. Most patients with mental health problems present first in primary care. So we decided several years back to move mental health resources into our primary care setting where patients present early. So now we have psychiatrists, 5 of us, psychologists, there's 3 of us, advanced practice nurses, another 3, social workers, I'm not even sure, I think there might be like 12, and RNs. all working on mental health problems in primary care. And that's has some advantages for seeing things a little earlier, because if they wait to see the specialist, it may be 3 months. And you think about what happens in 3 months if you have depression and you're not feeling well. Your primary might start a treatment, but if he or she doesn't have time to follow up, you may lose your job if you're not able to make it. Well, then you also lose your health insurance often. So there's a lot of a downstream effect on the delay of getting care. In primary care, there's also less stigma. It's the same place I go for my medical needs. If I'm sitting in a waiting room in primary care to see a mental health provider, it looks just like I'm being seen for any of the many medical problems. Whereas going over to the Generose building or the psychiatric facility can feel like I have to deal with the stigma. It also is a place where we track outcomes. In primary care, they all are used to tracking outcomes. They track blood pressure, they track diabetes outcomes. So it's really set up better to see if we're actually making improvement. So that's why you'll find if you go get seen in our primary care settings for a mental health problem, you often have some forms to fill out, because we're challenging ourselves that if we try a new model of care, does it actually make a difference or not? So looking at an innovation in care delivery that's not new, this is the one that's developed, it's been around a while, is this, I'll just mention this care coordination model that I've been involved with since 2008 at Mayo, but it's been around longer than that. In fact, there are probably 80 randomized trials with aspects of this showing that it works. If a patient presents to a primary care provider with depression, now we have a program for adults and kids in primary care. Instead of that primary care referring them and having them wait for 3 months to be seen, that primary care can either start a treatment or not and introduce that patient to an RN who's trained in this mental health issue. That RN will do a full intake with things that I need to know as a psychiatrist to make sure that I know what I'm trying to advise on. Then that patient and every patient in the program will be presented weekly to me or other psychiatrists reviewing cases. Now, these are patients I haven't seen, but in a morning, in 2 hours, I can review 40 patients and try to get them headed the right way, including if they need to see a psychiatrist. Whereas if I saw those patients, it would be more like 2 to 4 patients I'd be seeing. So the psychiatrist makes recommendations to primary care and helps triage, well, that person should go to this provider or that provider. Now we have also a program on eating disorders that we're working on. One of our psychologists is doing this very exciting thing where she is taking a way of managing eating disorders in kids that has been developed for psychologists to do. And she's training pediatricians on the key components. And she's finding that these pediatricians are now recognizing early stages of eating problems in young people and heading them off before they become full-blown eating disorders. And she's trying to get funding to test this in a larger way. Another one of my colleagues wants to get more active in addressing alcohol use upstream, in the sense of seeing in primary care if we can find people with risky drinking patterns who are not yet needing inpatient addiction treatment, and then use telemedicine and also a tracking application and intervention tool to address alcohol early in primary care settings before it has to go to specialty, because there's often a long wait to get into addiction programs. On our depression program, this is just some of our own data where we compared practice as usual, which is the dark orange, with collaborative care, or this model I mentioned that I can tell you more about if you're interested. And we saw at all these different time points, 3 and 6 months response and remission, that we had a better result. And that was very encouraging, and still remains true. We've had about 40 papers written on different aspects of patients in primary care that reference this program, and all of them have shown a better than practice as usual in terms of outcomes. And this is a different way of looking at these patients. How long does it take for someone to get fully out of depression if they go through regular care? That's the yellow. And if they go through collaborative care, that's the orange. So even though 86 days still to me seems like a long time to get to remission, and I want to speed that up, if you compare that with if they go through the regular system with all the challenges in the system, I like to say there's inertia in our healthcare system. So what do I mean by that? Well, there's the inertia on the patient side. I'm so depressed. I don't want to go through the phone trees and call in and try to get that appointment again. Maybe it'll get better. And there's the inertia on the healthcare side saying, you know, Mrs. Smith didn't show up. I wonder how she's doing, but I have 5 notes to write. I'll get caught up right now and I'll find out about that later. So that inertia on both sides needs someone tracking it. And our care coordinators are always checking to make sure whatever we suggested to that patient, either they're implementing it or we find out why it's a bad idea and we find another idea. So we're constantly adjusting their care to get them back on their feet, which is the reason why this goes faster. So why invest in this integrated care? This is a slide that we use, and we have an integrated behavioral health conference we put on every year. Well, it increased access to behavioral health care. When we started integrating into primary care, our referrals to the department of local patients went way down because we were able to get them better without having to wait for that department. Doesn't mean that we take care of everything. We estimate that maybe 80% of mental health problems could be managed in a primary care that was fully staffed for this model. It improves health outcomes. We have lots of evidence that this works. It improves health behaviors because we can also have psychologists working on what would help to get someone off smoking or better exercise or diet. It reduces costs, and it's estimated that, you know, these estimates are staggering, but and taken with a grain of salt because they have assumptions in it, but 26 to 48 billion could be saved if you fully integrated mental health and other medical care into primary care. And it can be modified to be delivered remotely. What are some signs that things are changing with this pandemic? Well, I referenced one of them. There's reduced barriers to telehealth now. When the emergency was declared, a lot of these regulations and billing barriers that were keeping us from being able to use some of our resources on telehealth have gone. Now, not all of them are gone, and we still have to work through some things, and we're worried that these regulations will come back. But this has led to an increase in the use of telemedicine. For example, from Blue Cross Blue Shield of Massachusetts on the slide, there was a 3,600% increase in telehealth claims in March of 2020 versus February of 2020, and 5,100% increase in monthly claims compared to over the year. So we are seeing a huge increase in telehealth. When we first had the pandemic go, all of our mental health folks were moved home initially, just for a few weeks. And we just switched immediately over to seeing folks through Zoom. And we actually had a very small dip in our care of patients. And we've had no trouble in filling our schedules with Zoom or in person. There's also been increased development of indirect ways of managing mental health and assessing mental health. This is just a little bit of it. There's an increased call to the National Suicide Prevention Helpline, which actually has been shown to be quite helpful for someone in need because they can call someone who's going to talk to them with some training 24 hours a day, which is hard to develop that in a regular health setting because folks don't work 24 hours a day. And that's the link to the suicide helpline if people are interested. There's also now a lot of mental health apps for your smartphone that are free. Several of them come from the VA, which are well researched. 3 of these on this slide. There's more of these. I just put 3 of the VAs because you'll find them in the same location. There's a COVID coach, which talks about mood and education and self-care. There's one called CBTI coach, or cognitive behavioral therapy for insomnia, which is free. And it's one of my colleagues who does this work says it's a wonderful app on helping you with sleep issues. And then there's also one on PTSD. And out of Canada, there's one called Mind Shift that is highly recommended to teach relaxation and mindfulness kinds of things. So there are options to get therapy resources through your smartphone. And some studies, and I don't go into it here, have shown that if you are very actively involved in online cognitive behavioral therapy and put the work in, you get as good a result as if you have a therapist helping you with learning that skill. There are other kinds of therapy that would be harder to say about. I just wanted to give one example that is outside of waiting on the mental health system. You know, I like the idea of why wait for Superman? What can we do ourselves? And this relates to this concept of how much is loneliness or isolation a health variable. And it turns out that some have estimated that loneliness impacts health as much as smoking 15 cigarettes a day. It has impact on cortisol, and cortisol is involved in mental health problems and in medical problems. And this is another longer conversation about how many studies have been shown that loneliness is related to poor mental health issues. So one group did a randomized trial of 240 patients aged 27 to 101 living alone with one chronic condition. And they got 16 lay people aged 17 to 23 and trained them in just some empathetic conversational techniques, and had each of them call 6 to 9 participants over 4 weeks daily for 5 days. They had these scales to measure loneliness, depression, anxiety, and self-rated health. All of them improved. All of those outcomes improved. And this was a randomized trial, which is sort of our gold standard to say there was a real impact here. So I think that's kind of exciting. There's another similar study that I didn't quote here that's interesting out of Zimbabwe, where they realized that when they didn't have enough mental health providers, but they realized that many people found that they got their direction from their elders. And so they put these benches around, I don't know if people have heard of this, these benches around where they would have one of the elders sit and you just sit by the elder and talk if you're having trouble. Well, initially, when they called them mental health benches, of course, nobody sat on them. But then they took the label off and had a more neutral description. And many people would go and just try to start working out their problems through that kind of connecting with someone, which I thought was another wonderful example. So many times when I'm giving talks like this, people will say, well, what about me and those I care about? I'm stressed by this pandemic. What are some things that are helpful? Well, back earlier when things were starting, towards the bottom, this limiting connection with the news was something I had to tell lots of folks. They'd say, I'm just stressed out by one thing that's bad after another. Now that's still happening with all the shootings and things. And I'm trying to get my patients to limit their contact with the news. They need to know what's going on, but they don't need to stew in it. Exercise is really critical, especially if you get short of breath when you're exercising a little bit, so that you're pushing your body. That can be a strong benefit for mood and anxiety. It kind of burns off some of that adrenaline. And so planning some exercise into your week, obviously is getting easier now that's warming up, but it was harder in the winter. Avoiding addicting chemicals and a healthy diet. Sleep is critical. I always ask my mental health patients about their sleep. All the mental health problems often have a sleep issue with them. And we're looking at, are you sleeping in a room that's too hot? Is it cool enough? Is it quiet? Are you using caffeine up to the evening? Are you using your electronic devices a lot as you're lying down and turning on that melatonin system so that, or turning it off so that you can't get a normal sleep? Getting into nature, this is one of my favorites. I find it's very healthy to get outdoors into something, a natural world. It's a very healing thing. As you heard, isolation is a critical challenge. So it's ideal to get to where you can see people's faces through Zoom, or now that we're vaccinated, in person would be ideal. And many patients, my son was amazingly when in quarantine in China. He wasn't infected, but he had to be in quarantine anyway. So he spent 2 weeks in an apartment by himself, and I thought he's going to go crazy. But he found that he got into a routine every day, and he came out in better shape physically and had more things read and was on track. So a routine can be very helpful when you're suddenly locked down or in these different circumstances. And the NAMI, the National Alliance of Mentally Ill, there's a link at the bottom, and I've shared these slides to what are some signs that there may be more than just worry going on, that you might need to seek help. So here's the person who taught me the most about mental health. So I thought I'd include her on this end of this slide here. And she's actually in the audience, so I'm a little nervous what question she's going to ask me. But I thought I'd stop now and open it up. So I'll stop sharing here.
So, Mark, it was interesting. I was reading in the New York Times on Friday that there's been a 5% decrease in suicides in the last year. I thought that I was expecting that would be high.
Yeah,
but it was mostly in the white population.
Yeah, no, I like the fact that you qualified it towards the end. I think that when you see these reports coming out, it's always important to ask how did they get their data compared to the last study, and is the denominator the same group? But I think that I don't know what we can make of it. Suicide's a big thing to talk about. I don't know if the whole audience wants to go into that topic or not, but suicide is a complex thing, and there are times we've had. My daughter, for example, is a pediatrician in the Twin Cities. They have more kids overdosing and coming in than usual. Now they don't die, but they're attempting suicide. So one of the things you'd want to know is what happened to attempts. Did they go down? So I think it's a nice statistic, but I would just want to know more about it, and I haven't had a chance to look at that. Other questions? We have about 9 minutes. I see a hand up. Daphne, did you want to ask a question?
Mark, I put my question in the chat, but I can read it to you if that's easier.
Whichever, I can open it up. Well, yeah, go ahead. Might be good for everyone to hear it.
So I lead a community healers team at Christ United Methodist Church, and when the pandemic remits, we're planning some population-based health promotion strategies like play groups to help get people reconnected to you and into nature. But we know that our congregants are not immune to pre-existing and exacerbated mental health challenges from the pandemic and the isolation that it's caused. So we want our work to be trauma informed, and I was wondering if you can recommend any resources for us, and what recommendations do you have for sort of a PTSD triage plan? Because we'll be in a place to notice symptoms among our fellow members.
Yeah, that's interesting. So you would be inviting individuals to go out in nature together? Is that the idea? Okay. Yeah. No, that's great. I'd be happy to connect with you on afterwards. You want to email me or something, and we could talk about it in more detail. But generally, it's important to kind of understand that patient's level of stability at the time that you're offering to have them be involved. And to what extent do they have other resources in place, which is helpful. The trauma aspect of mental health is a good another 1 hour or even some all day talks about trauma, and it's way more common than we all realize. That trauma broadly defined is very, very common, but even specific types of trauma are hugely common. So knowing to what extent that person is highly symptomatic, not sleeping, not functioning, and disconnected. So I would probably want to get maybe a few screening questions together to try to say, how are you doing right now, and what are you plugged into, and what are your expectations for this this thing that we have together, to try to make sure they're realistic. But sorry not to get more detail without having more chance to understand what you'll be doing, but feel free to send me an email.
I certainly will. Thank you so much.
Sure. Others, we're going to run out of time. We only have 6 minutes. So any other quick questions?
Mark, I'd like to ask a question.
Uh-oh.
Well, we've had many discussions over the years about the poor coverage of mental health problems with insurance. And I was just wondering if you have seen, because of COVID, maybe more coverage for patients for mental health issues or not?
Yeah, I feel like I'm seeing things on an individual level, and so it's hard for me to know if that's a representative of a broader thing. But my experience has been that there's a little more, there has been a little more parity kind of opportunity, but still it's amazing to me at how I will be spending 4 hours with an insurance company for something that is not that expensive for a patient. So we're sometimes penny wise, pound foolish. And there's a lot of barriers to simple things. Even within one medicine, there'll be a barrier to one formulation of that medicine and not the other. And you don't know that until you actually write the prescription and then following up. So there's been partial improvement, but I don't feel that we've made any fundamental change.
George, I think you have a question.
Unmute.
Oh.
Oh, hi, this is Tony. Say, I'm just wondering, have you seen that it's tougher to place adolescents or children into a long-term placement for mental health needs during COVID? Has it been tougher to find places that will take kids during this time?
I work with adults, so it's secondhand information, but I would say very likely that that's true. I've heard that from my daughter, who's an intern in pediatrics in the Twin Cities. And I've heard that from the child colleagues of mine that are trying to take care of kids, that there's a bigger backup. Usually there's beds available on the child inpatient unit compared to the adults, and they tend to be more full lately. And there's many, my daughter tells me, and I've heard this from other people, many of the kids will come in, even though they've done an overdose. You can imagine the stress on kids if they've been in a relatively unhealthy home, and now they're not allowed to go to school, and they're there more often than they were before, and they're trying to learn through a video with no supervision. I've had patients come in and say, I know my kids aren't learning, but if I don't get to work, we won't have food on the table. So it's been, I think, a lot harder for kids to get into placement with the restrictions on COVID, but also the increased demand. So I think you're tapping into something. I just don't have data for you. Anyone else? Maybe something in the chat. Okay.
Hi, yeah, this is Anna. I'm kind of building off of that last question. I work with kids with autism, and I'm currently back in school to be a clinical social worker, but looking kind of at that childhood adolescent piece based on even your current work with adults, are there additional resources or supports that you think will be needed for our kids in the next couple of years as they're going back to in-person school?
Oh, yes, definitely. I think how I was talking to individuals about this who work with kids. I see my sister on here. My brother-in-law works a lot with the kids. And, I think there's certain numbers of kids that almost have a lost year in regards to some of the things, social, obviously, and also learning, that they'll be trying to figure out now what happens when the school opens up more and how do they catch up. And then, of course, they've been experiencing some challenging events, so they'll need support to how to metabolize those events, and they've had losses just like the rest of us. Do you say you're working with autism primarily? Is that right? Or?
Yes, that's correct.
Yeah. Well, one interesting thing I don't know if anyone's heard of the ECHO program, but it's out of New Mexico. It's a really cool program. Since we don't have time, I'll just mention it was done first in hepatitis, but it's where someone who's very well versed and knows a lot about a condition, hepatitis, now in this case autism, gets into a weekly or monthly meeting with a place where these patients are presenting. In this case, it was primary care. So there's an ECHO program at Mayo by a pediatrician and a child psychologist in primary care on autism. And what they're doing is they're helping these primary care providers know what are the strategies they can use in these rural settings, because with this type of ECHO, you can bring expertise from a place where there's lots of resources to a place where there's very little, and start that kind of guidance. So but the autism area is an area, I think, where there's a lot of opportunity. So I think you'll have some choices coming up in job options, I hope, for you anyway.
Thank you.
Yeah.
Mark, I have a question. What about the anxiety of people of color right now, especially with what's happening in Minnesota and the trial, and also with Asian Americans being targeted? It seems like that the Southern Poverty Law has said there's a rise in hate groups this past year. And how does that add to the anxiety? And are those people receiving help?
Yes, I think you've tapped into another subgroup. Like I mentioned, there's a number of subgroups. That's a very important subgroup, our minority individuals who are, I used to work in a refugee clinic, and I would run into that a lot in the Twin Cities. It's a major problem. We may or may not always be the place where they come initially for help. Distrust of the health system, language barriers, lack of access to the internet, but we are certainly open to that, and we actually have permission to start a refugee clinic in primary care, but it's been hampered by some of our immigration policies in the last few years, but I think that may change going ahead. But certainly I have run into individuals who look at me suspiciously as a member of a group because of what their experience has been, and we have to work harder at forming a therapeutic relationship because they have real experiences of being treated differently than I do out there in the world. So yeah, it's a big problem. Now I tend to see people who have a diagnosable condition. That isn't the same as someone who has real anxiety or real loss. They may go to their church, or they may go to their family, or they may go to other community resources. So I may also not see as many of those folks as others do.
How
I have a lot of job security, let me put it that way.
How many people of color are in your profession?
Oh, I can't answer that. Across the country, I don't know the answer at the top of my head. But I certainly we have a variety. We have a lot more of a male-female equality there than we used to when I started training. But there are you know, I used to work with the Hmong in the Twin Cities out of training, and it was really interesting to see their progression from coming from a society where they had very little training there was no written language, and then now there are Hmong providers, and we're seeing that now with Somali providers as well. So it's a great thing to see more diversity, but I don't know the numbers.
Mark, I want to thank you very much for this presentation. It was just excellent. I've got a couple of comments relating to your integrating these services, mental health services, into primary care. I think that's really, really going to be effective. But you mentioned the insurance issue, and I think there's two prongs there. One, of course, is the insurance industry itself, you know, is protecting itself from more cases and more expense. So sometimes you have to force things on them, and I think maybe we need to take a look at the political route and maybe force this into some kind of a package of healthful living and healthful care. And maybe legislation is required for that. But internally, I'm wondering this. My experience in the insurance industry has been that many times the providers, it really makes a difference the way they code things and the way things are coded within the system, and then they go to the insurance coverage, and the insurance, if it sees, oh, that's mental health, then you're limited to the number of times, just like therapy, physical therapy. You can only have so many for referrals. So is there a way internally that the health systems can do a coding system that matches your work with putting more of this into primary care?
Yeah, that's interesting. I can say a couple things about that, another longer conversation possibly. But interestingly, the model I described for you for depression, it's called, the abbreviation is COCM, or Collaborative Care Management. Medicare came out with codes for that about 4 years ago, but they were so cumbersome and confusing, nobody used them initially. Now they're out, and we just started billing all these insurance companies for them. And we're spreading this into rural clinics so that more people get started down the right track. And most of the private insurance companies are paying them. One of our legislative needs is to get our state to pay for them, for Medicaid. About 12 states have gone that route. Minnesota is behind, which is sort of amazing to me since we tend to be progressive. But there's been such fighting in the legislature about other issues that's not high on their priority list. But in the realm of good news, Blue Cross Blue Shield of Michigan has hired several of us. I'm training there to spread this collaborative care model across all their primary care practices. So I'm doing these Zoom conferences 3 times a year to train all these primary care practices to spread this. And Blue Cross is paying for all the training and increasing reimbursement because they realize that to get patients treated early in their mental health journey is actually a good investment for them. And now Medica is coming to us in integrated behavioral health and asking, could they partner? But it's, you know, it's bigger than any one insurance company, right? Because any clinic that tries to change the way they deliver care is struggling with 50 different rules and regulations coming in their door. And what we need is insurance reform, obviously. But I think if we could get the state to pay for collaborative care, that would be a real plus.
I think that's a great approach. And remember the experience that we had with preventative medicine. Well, this is preventative medicine, and the insurance companies have started to accept that, and I think our state has started to accept that. We've got to get some of our politicians understanding that preventative medicine in the long run saves money.
Yeah, I agree, totally agree. Other-
So, Mark, you sent me the slides and I can see that we can somehow put them on our church website if people are interested. This will be recorded, so you can also view it on the church's YouTube site. So you can see it there too, but right now it'll probably take us a week because Oliver's out of town to get that published on our website.
Sure, sure.
Where
Well,
will it appear, Kathy?
This talk, our forum,
Yeah, and the slides. I have a hard time finding it on our website.
well, it won't be on the website right now, Dean, but you can go to YouTube, Christ United Methodist Church Rochester, and go to playlist, and there's a listing of our forums under
That's-
Faith to Life.
Where will the slides be?
The slides, I will talk to Oliver, and I have everyone's name down so I can have Jenny email you with that information.
well, it's nice to see some familiar faces.
Well, I want to thank you, Mark, for doing this. I'm just been sitting here thinking how it would be so good to have a forum maybe at some time that we could really look at this question of the stigma of mental health. And why is it we have such a hard time recognizing this as a true health issue? I think all of us having heard today, checking our own assumptions about why people get mental health issues would be very, very good response to this presentation. But I may be having a side conversation with you about another forum.
Okay.
Thank
right.
you. Thank you so much, Mark. Obviously, this is a very important topic because we have lots of people join us this morning. So thank you for taking the time to do this. We really appreciate it.
My pleasure, and wonderful questions, and feel free to reach you. My mother knows how to find me. So if you trying to reach me, he's got a link.
Thank you all for coming. And our next forum next month will be presented by Planned Parenthood.